So given that, given the pressure to get patients better faster and get them out of the hospital faster and save healthcare dollars, I would think that combining a mood stabilizer with an atypical antipsychotic would still be an appropriate treatment. So I would say that could still be level 1. Now level 2, I would suggest here thinking about a mood stabilizer plus ziprasidone or paliperidone. And again, as we said, the reason why they're down there are because the paliperidone and ziprasidone both had failed trials. The combination did not work better than monotherapy, although the combinations were superior to monotherapy numerically. So I think it's still a worthwhile strategy as a second level treatment. Carbamazepine monotherapy or combining carbamazepine with lithium or valproate could be appropriate here. But before you get to level 2, you will try many first-line treatments or the level 1 treatments either in monotherapy or in different combinations. So it's seldom that you will be going to level 2 because majority of your manic patients will get better with level 1. And then looking at level 3, again, I would delete the different 2-drug combinations of level 1 drugs because you will have tried that at level 1. This is where you might be thinking about something like clozapine or clozapine plus lithium or valproate. And of course, if patients don't get better with that strategy, which is extremely rare, you go to level 4, and that's where you're thinking about 3-drug combinations or ECT or drugs, experimental drugs such as tamoxifen. So that would be recommendations for mania. Now let's move on to treatments for acute bipolar depression. And again, I've listed here some of the treatments that clinicians commonly use. The trouble with the bipolar depression is that the evidence is not very strong for many of the options that we currently use to treat depressive symptoms in bipolar patients, unlike mania, where the evidence is very strong for many medications. So let's look at what the data suggest. Now, before we do that, here's what we have from your Florida group in terms of treatment recommendations. Again, you have level 1, level 2, level 3. So keep these in mind, and we'll come back and revisit these after we reviewed the data for bipolar depression, the placebo-controlled trials. So let's look at the mood stabilizer story. Now, many guidelines recommend using lithium as a treatment or a mood stabilizer as a treatment for acute bipolar depression. And this is primarily based on some of the older studies suggesting that lithium is more effective than placebo in treating bipolar depressive symptoms. And some of those trials had a very small number of patients. But here is a recent study that looked at the efficacy of lithium in comparison to placebo. And this study had a fairly large number of patients with acute bipolar depression. Unfortunately, this study showed that lithium was not better than placebo, at least statistically, whereas the quetiapine, which was also tested in this trial, 2 different doses, both 300 and 600, quetiapine was better than placebo, but lithium unfortunately was not, which raises some questions about how effective lithium is in treating acute bipolar depression. However, one of the caveats with this study is that the mean serum lithium levels in this study were around 0.6. And I think based on some of the research that had been done in the past, it would appear that the serum lithium levels would have to be around 0.8 or above for the lithium to work well. So perhaps one can say, based on this study, that we haven't actually proven that lithium does not work. We may need more studies. Now, here is a NIH-funded trial, and the objective of this trial was to really figure out, when you give an antidepressant in combination with a mood stabilizer or an atypical antipsychotic, do more patients get better with the combination compared with a mood stabilizer and a placebo? And unfortunately, in this trial, the results showed that the patients that met durable criteria, which was defined as 2 or fewer depressive symptoms on the DSM-4 checklist, there was really no difference between the two groups. So about a quarter of patients in each group met the criteria for durable recovery. So this study is suggesting that antidepressants, when they're given in conjunction with mood stabilizers, are not effective at treating acute bipolar depression. But of course, one of the challenges with this trial is that it is unclear what the characteristics of these patients were. So in other words, could these patients have been tried on antidepressants previous to going into the double-blind phase? So in other words, were these patients antidepressant resistant, and is that why they didn't do better in the trial? So that's one of the possibilities. And secondly, many of the patients that participated in this trial were recruited from tertiary care academic centers, which typically tend to see more difficult to treat patients. So again, for those reasons, I don't think we can say categorically at this point in time that antidepressants do not work for acute bipolar depression. Now, here is another study that was done as a part of the Stanley Foundation network, where they took a bunch of patients with bipolar depression that were taking a mood stabilizer, and they randomized these patients to one of the 3 groups. Addition of sertraline or bupropion or venlafaxine. There was no placebo group in this trial. And they followed these patients for 1 year, and they looked at the response rates in each of these groups at 10 weeks and at 1 year. And what they found was that at 10 weeks, about 40 to 50% of patients met criteria for response, and at 1 year, 70% approximately met criteria for response in each of these 3 groups, with no difference in the efficacy between the 3 antidepressant medications. However, they also tracked the switch into hypomania and mania, and as you can see, a significant proportion of patients in this trial had experienced hypomania and mania. But of course, you could argue, given that there was no placebo in this trial, that the manic and hypomanic episodes that these patients experienced, you could argue may have been part of the natural course of the illness because there was no placebo. But the fact, though, is that the switch rates were significantly greater in the venlafaxine group compared with sertraline and bupropion group at 1 year. So at least the least you could say from this trial is that venlafaxine is much more likely to switch patients into mania compared with sertraline and bupropion, and therefore, if you're going to use antidepressants to treat bipolar depression, you may not want to use venlafaxine unless you've exhausted SSRIs and bupropion. What about valproate, a mood stabilizer? This hasn't been tested in any large double-blind placebo-controlled trials. However, there are 4 small trials, out of which 1 was negative and 2 were positive. So 2 positive studies have been published. These are by Laurie Davis and Nazar Gami. And the 2 unpublished studies, Gary Sachs' study was negative, and Muzina's study was positive, and this will be published in the near future. But if you look at the sample size, they add up to about 140 patients from all these 4 trials. So still we're talking about smaller numbers. Now, we did a meta-analysis taking the data from all these 4 trials, and basically what we found was that the response or remission rates were greater when you combine the data from all the 4 trials compared with the placebo group. So this is suggesting that valproate monotherapy may have efficacy in treating depressive symptoms, but of course this needs to be confirmed in larger double-blind placebo-controlled trials. Lamotrigine story is interesting. The first trial that was done and published in 1999 showed that lamotrigine was more effective than placebo in improving depressive symptoms. And following that, GlaxoSmithKline did 4 other trials, hoping to get at least 1 positive trial so that they can get the FDA approval. And unfortunately, although in each of these trials, more patients got better with lamotrigine compared with placebo, the difference was not significant. So GSK gave up after doing 5 different trials because they couldn't get 2 consecutive positive trials. Now, more recently, John Geddes did a meta-analysis taking data from these 5 trials, and basically these data are suggesting that